Hello, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to look at the infectious disease theory and one that really needs more attention in research. That is the possibility that a virus or bacteria could actually be the cause of the onset of Alzheimer's disease. So welcome to our guests. I see we just lost Dave, but hopefully he's coming back, or Brian, sorry, Brian's coming back soon. So with me on this panel, we have three, I'm just waiting for Brian to come back right now. Got him. Okay. We have three very distinguished researchers that we're bringing to you. And I'm really grateful to all of them. When I call your name, just wave your name so that the audience can see. Brian Balin is a professor of neuroscience and neuropathology at Philadelphia College of Osteopathic Medicine. Dave Devanand is a professor of clinical psychiatry and neurology at Columbia University. And Ruth Itzhaki is a visiting professor of the Institute of Population Aging at University of Oxford. Thank you so much to all of you for joining us. So I'm just going to start with the very basics, and I'm going to, give all of you the chance to answer this, but let's just start with understanding why exactly in the first place were we looking at a bacteria or virus microbe as the root cause of Alzheimer's?
Okay, I'll begin,
Go ahead,
I guess.
Brian.
Okay, well, this goes back actually to the days of Alzheimer and Oscar Fischer, when they were first identifying pathology in brains of individuals that had died with severe dementias. And it was proposed at the time with Oscar Fischer that potentially an infectious agent could be involved. And they thought it was potentially a filamentous type of infectious agent because of they saw these silver-stained, large filamentous structures in brain tissue, and they thought potentially something like that could be there.
So filamentous meaning like filaments of a bacteria or a virus? What exactly does that mean?
Correct. It would be like a long, extended piece of bacteria, like we call it filamentous, meaning because of the filament-like nature to the organism. And,
right.
and the filaments that we see are amyloid filaments and tau filaments that accumulate as the pathology in brain tissue. Well, back then they only had silver staining to really look at that. They couldn't really identify beyond. But it was proposed even then that there could be an infectious agent. Well, that sort of went by the wayside for a long period of time. And it wasn't until really the 1980s Ruth really started a lot of this work with finding herpes simplex virus 1 associated. She can talk about that, obviously. And then more serious investigations started in the late 80s, the early 90s, mid 90s, and going to current, where we started finding a number of different infectious agents in human brain tissues. These are now Alzheimer individuals that went to autopsy. We examined the brain tissues and found evidence for these infectious agents. And based on that, we think, well, maybe infection is involved in the pathogenesis of the process or the development of Alzheimer's disease.
So Ruth, how uncommon is it to find these types of pathogens in the brain? I mean, obviously we're getting the information through autopsy. So is it quite common, or is it only seen in Alzheimer's or dementia patients? What do we know about that?
Well, no, it's not at all common, at least until about the end of the 1980s. The brain was thought to be sterile, nothing, no organisms in it. As far as I know, nobody thought there was any infectious agents there at all. And we decided to look for a virus in the brain because two main reasons. Firstly, it had to be a fairly common virus, and herpes virus fits that very well. It's very common. Nearly everybody is actually infected by it. Doesn't mean to say they're affected by it, but they are infected, but they can be completely asymptomatic without any symptoms. The reason why we look for herpes virus also was because in a very dangerous acute disease, which luckily is very rare, only affects about 2 or 3 people per million, herpes simplex encephalitis. That's an acute illness, as I said, and people can and do nowadays recover from it with proper treatment, more or less recover. That in that herpes encephalitis, the brain shows in some regions a close similarity to the same regions in Alzheimer's disease. So it was suggested by a neuropathologist called Melvin Ball. He said because of the similarity, it's worth investigating this further. That was in about 1984. And we started looking for herpes virus in both Alzheimer's disease brain and elderly normal brains by a technique known as PCR, polymerase chain reaction, which you've probably heard about now because it's commonly used to look for SARS-CoV-2 virus. But then it only just started being used. So we were fairly early on, and we were the first to look for the virus by that technique. But a few people had looked in normal brains for infectious agents. There was some suspicion there might be something there. But the techniques they used were very, very insensitive, whereas PCR, as you probably know, is extremely sensitive, very, very sensitive indeed. And so detection would be, I wouldn't say it's easy, it was very prone to contamination, but we found it there anyway by taking very meticulous care not to contaminate our samples. So the answer is people now are finding more and more infectious agents. I don't know whether Brian and Dev would agree with this, but it seems that there are quite a lot of infectious agents in brain, but probably a lot of them are doing absolutely nothing. I should have said the third characteristic of herpes is that it can lie latent, dormant in the body for a very long time. And one would assume that an agent that causes Alzheimer's disease, if it were to cause Alzheimer's disease, it would have to stay in the body for a long time because the disease is very slow. People deteriorate on the whole very slowly, perhaps over a period of years, up to 10 or so years. But Dev could correct me on that if there's anything not quite right, because I'm not a clinician. So that's a rather long-winded explanation, sorry.
No, that makes a lot of, that's a really good background on how we got there. And Dev, I'm curious, because I know your study, your research involves the herpes virus. Could it be as simple as, and maybe we should clarify that this is one hypothesis of a disease starting the pathogenesis of Alzheimer's, but do we all agree that it could start in different ways, not only a microbe, if this is indeed proven to be true? Is this just one pathway?
I think you're bringing up a very key point that Alzheimer's disease, in a way, is the end stage of many problems or insults to the brain. And so the associations that have been seen with infectious agents like herpes simplex virus, we also see with some other conditions, such as cerebrovascular disease confounding the clinical picture. And as people are living longer, we are finding, and this has been found consistently, that when somebody is 85, 95, 100 years old and dies with a diagnosis of Alzheimer's or doesn't have a diagnosis of Alzheimer's, it's very common to have Alzheimer's disease, vascular pathology, sometimes Lewy body pathology, which is linked to Parkinson's disease. So multiple neuropathologies exist in the brain by the time one gets into the 8th, 9th, 10th decades of life. So the idea that there may be multiple factors leading to multiple pathologies is gaining credence. In medicine, we always like to say one cause, one disease, but as we grow older, we often don't have one cause and one disease. I wanted to point out a couple of things in Ruth Itzhaki's work, which she didn't allude to, which is in basic science studies, some from her lab and some from others, the herpes simplex virus can be associated with increased amyloid and tau protein formation in animal models. And when you give antiviral medications, the one we are studying is Valacyclovir. It's generic. There are several of them. By the way, they're very effective clinically against herpes simplex virus 1, which is oral herpes, and herpes simplex virus 2, which is genital herpes. They're highly effective, highly specific. And when they're tested in animal models or cell culture models, they have effects against amyloid and tau. So there are a number of converging lines of evidence. And in the last few years, there have been epidemiological studies in the community showing an association between prior exposure to herpes simplex infection, to a smaller extent, herpes zoster infection, which is what causes shingles, and Alzheimer's disease. There were a couple of studies out of Taiwan which showed a very robust effect of antiviral medication treatment in reducing the risk of Alzheimer's. Those findings have been replicated, but with a much smaller effect size, meaning the reduction in risk from the antiviral drugs is not as robust, but it is still there. And these are studies coming mainly out of Europe and one out of South Korea. So we have a lot of converging lines of evidence. The one thing we don't have yet, which is what I'm trying to do, funded by the National Institute of Aging, is a prospective clinical trial comparing an antiviral medication in the study we are doing, Valacyclovir, to placebo, to show that there's a clear difference, because these symptoms can fluctuate over time, cognitive performance can fluctuate over time. So you need a placebo to control for that. In a trial, we are doing it. It's been taking a while, but we are in the process of finishing recruitment for that trial.
Okay, so and I'm interested in this because I can imagine a lot of people would, I mean, like Ruth pointed out, a lot of people have the herpes virus, and although it could be dormant in your system. So would it be that in order to research this hypothesis, you would need people who already have plaque in their brain, or it's just they need to test positive for herpes? And how do you determine whether or not giving people an antiviral medication actually will stop the process from happening before? Because presumably these are people who don't have Alzheimer's, and you can't reverse it once it's started. So can you explain that to me so we can understand that?
Well, you've raised 3 or 4 excellent questions in your comments, so I'll try my best. So it's easy to test whether somebody previously had exposure to a herpes virus with a blood test. It just looks at the antibodies. We call it IgG, immunoglobulin G. So whether you had the herpes infection a couple of years ago or 50 years ago, it will still be positive. And it's fairly accurate, and it's done by routine labs. So knowing whether a person previously had exposure is not difficult. We are talking about long ago exposure among older patients who have Alzheimer's. And I can tell you from our clinical trial, we've had a little over 100 people who've joined the trial. It's almost always IgG, saying old infection, not IgM, which is an acute recent infection. It's very rare in the Alzheimer's population because of the age range, as well as their daily behavior is obviously changed for somebody who is in the older age category. In terms of what do you look at, we don't have a biomarker for herpes simplex virus infection in the brain that we can image. We have that for imaging amyloid protein. So we look at prior herpes infection with its signature in the blood, and we look at what's happening in the brain. We change in amyloid because we cannot directly assess in a living person, how much herpes virus DNA is in the brain. And obviously, the most important thing is the patient should improve clinically in terms of their cognitive and functional performance. So those are some of the outcomes that we are measuring. And there are also other biomarkers one can look at in the blood as well as in the cerebrospinal fluid with a lumbar puncture, but those are still more investigational. One point I'd like to make is with the antiviral drugs, it has been shown with studies in multiple sclerosis that you get significant concentrations in the cerebrospinal fluid with a spinal tap or lumbar puncture. So it's clear that the drug in humans, in clinical populations, is entering the brain. That's quite important because normally it's just given for peripheral infection.
Right. Okay. So we've talked about the herpes virus, but there's others around microbes that are entering our brains or evidence of that. Brian, you are studying one, chlamydia. I can never say the last word. Is it? You say it.
Pneumoniae.
Pneumoniae. So what led you to research chlamydia pneumoniae, and what do we know in terms of its pathological effect on the brain?
So what we have found is that when we first got into this particular field of study, we actually, I was looking at the atherosclerosis literature. So this is blood vessel disease. And chlamydia pneumoniae was proposed to be involved with that going back to the early to mid 1990s. So in a discussion with a colleague of mine, Dr. Alan Hudson, he and I started this whole process and finding this, we thought, well, why don't we try looking in brain tissue because of that involvement in blood of this organism and see if we find anything in diseased brains or normal brains, et cetera. So he did, in his lab, he did a lot of PCRing, like Ruth had mentioned PCRing, looking for a genetic signature of this infectious agent in brain tissues. And it was disparate that it came out that finding it in Alzheimer's disease and not in control brains or age-matched control brains, which was non-Alzheimer's, non-neurologically affected brains. That led us into the study that we started publishing in 1998 to current. So this organism is an intracellular bacterium, meaning it acts like a virus actually by invading our cells and starts to live and set up shop in our cells and can become persistent. In that way, it's very similar to what would happen with herpes, that you'd have an infection that could happen for a long period of time and persist for a long period of time in our tissues, particularly in our brain. So after many studies, we've realized that this organism as a respiratory pathogen can actually get into the brain through our olfactory system or our sense of smell and go into the brain that way, but also go into the brain through the blood by infecting white blood cells from lung tissues when you have surveillance in lung. So you have two mechanisms that this organism can actually invade the brain. We actually are of the belief that it's the olfactory pathway first, partly because the Alzheimer's disease really starts in the entorhinal cortex, a part of the brain that is connected to olfaction. It also can begin in a brainstem region called the locus ceruleus. So we have multiple regions, but the entorhinal cortex is really key, we think, and connected from the entorhinal cortex, you have connections then going into the hippocampus. So what do you find in the disease symptomatology-wise? Well, you find change in sense of smell early, and also short-term memory is affected. Well, we think that you're setting the stage here with this type of infection, generating inflammation, glial responses, generating amyloid. Some of our studies have shown that you infect cells in culture and you will produce amyloid. Well, just about every cell we've infected, a monocyte to a neuroblastoma cell, glial cells, endothelial cells, process this amyloid that's in their membranes and processes it into A beta or beta amyloid. In particular, the 1 to 42 form, which is the most commonly found form in plaques for amyloid plaques. So we have multiple evidence here that this organism also can be involved in the process. And there was a recent study out from Taiwan. Again, Taiwan, they're looking at population studies of showing that people that were diagnosed with chlamydia pneumoniae pneumonia, having a pneumonia, that they had a 1.6 fold increased risk of developing Alzheimer's disease. Now, there's over 1,000 patients were looked at, et cetera, compared to almost 5,000 controls. So there is a story here where we think that these organisms, the herpes, the chlamydia, maybe Borrelia, maybe some of the oral organisms also, can actually start this process, can actually begin the change in the brain that would eventually lead to what we're calling Alzheimer's disease. And it goes to Dev's point as well about the clinical trial. We need to do clinical trials actually with individuals that either have a risk because of noting that they have been infected and are older individuals, or that show mild cognitive impairment, especially amnestic mild cognitive impairment, or very early Alzheimer's disease. And we need clinical trials on a lot of these effects of different organisms. This also goes to the point I wanted to make about multiple infections in Alzheimer's disease. If we use the analogy that Alzheimer's disease is really like what we call pneumonia, right? So pneumonia can be caused by viruses, be caused by bacteria, can be caused by fungi, can be caused by aspiration issues, okay? Like something that now your food particle getting into your lungs. So you have multiple ways you can get to the end point we call pneumonia. Well, we think of this as multiple ways you can get to the end point we're calling Alzheimer's disease.
So, okay, this is all really, really interesting. And we have a question that's come in from one of our viewers saying, I'm curious on your thoughts about low dose antibiotics for Alzheimer's patients. And this one in particular was someone having a recurring UTI, but I'd like to apply that question to the hypotheses. I mean, obviously we treat bacterial infections with antibiotics. Could it be as simple as really treating any type of infection to stave off later having a more detrimental impact on our brains? I know we need more research around this, but is that credible to think, like Dave was saying, really starting the medication now if there's a presence of these microbes to stave off later impact? Oh, you're on mute.
It's an interesting question. So one starting point, which is very important to understand for all of these discussions, not only with microbes, but with drugs. Most of the infections we have, bacterial infections, most of the antibiotics that are given are peripheral, meaning they're in the blood, they go to the organ in the body, but they generally do not enter the brain because the brain has something called the blood-brain barrier, which prevents most compounds from crossing into the brain, and it's a self-protective mechanism that the brain has evolved over time in humans. So if you're going to treat with antibiotics, the infections can be treated, bacterial infections with antibiotics, viral infections with antiviral drugs. And the epidemiological studies for herpes simplex and chlamydia, as Brian pointed out, show that if people were treated effectively with these agents, they're less likely to develop Alzheimer's. It's not a big effect, but it's an effect. So it could be that when there's adequate and robust treatment, the organism is essentially eliminated and you don't have particles, viral or bacterial particles that can sort of infiltrate slowly and get into the brain and sit there and be latent for years and then create problems. So that's, it's a very difficult thing to study because people take antibiotics in different ways and many people are not fully compliant. The analogy that comes to mind is Lyme's disease. The treatment for Lyme disease is antibiotics, but these are high-dose antibiotics, multiple antibiotics for an extended period of time in order to treat Borrelia, which is the organism causing that. So I think there's merit to the idea of effectively treating infections with antibiotics or antiviral agents, depending on the organism causing the particular infection. But I think it's very hard to study it and prove that point, but it probably says something very broad. Treatment should be effective for a long enough period of time. And just generally, it's almost like a general health comment rather than something that specific. I don't know if Ruth or Brian have thoughts on
actually,
how we
Ruth,
can study that.
I wanted to follow up with Ruth on this because do we know exactly how long it will take something like the herpes virus to get to our brains? Is there, like, you talked about the dormant stage versus the active stage, but do we know, like, once we're infected with the virus, how long it actually takes to travel to our brains?
No idea, but and we don't even know what age it gets there or what range of ages. I suggested it gets there probably in late middle age as the immune system declines. But there is a way of looking for it, but I've not yet been able to get specimens. You can find a lot of information from the cerebrospinal fluid, but because it's usually very uncomfortable to have it taken, it's difficult to get specimens of that. But that would yield, one could do that very, very nicely. I've tried to find out if one got a range of ages and find out when there's evidence of a virus in the brain by looking at the CSF, but specimens are very rarely available, certainly not over a range of ages. But no, we have no idea how long it would take. Probably be fairly quick, I would think, but that's not a limiting factor. I think what is a factor, what is more important to be discovered is when it gets there. And I think, as I say, it's late middle age, and that's perhaps when people could start taking antiviral agents, which some of which are the one that Dev is using is really very safe. And I think you would agree, Dev, that side effects are minimal. So
okay,
it could be well taken early on.
Okay, and there's another question. Tuberculosis meningitis is an example of a treatable intracellular brain infection. Is it possible that, like TB, we need to give multiple antibiotics for an extended amount of time in order to achieve high enough brain concentrations to eradicate organisms like chlamydia and Borrelia, and also otherwise known as Lyme disease?
It's yes, it's quite possible you would have to use an extended period of time, but also different antibiotics. So it wouldn't be like one antibiotic that would be used in that approach, potentially even going to 2 to 3 different antibiotics. Also, by doing that, you're minimizing the risk that you're going to have some type of resistant mechanism from the organism developing so that you can't actually clear it. But the antibiotics there, like rifampin, rifabutin, the macrolide antibiotics, the fluoroquinolone antibiotics, these are ones that can get into our cells and affect an intracellular type of infection. But it might require, like with the Lyme disease therapeutics and therapy regimens, an extended period of time to use those to see what type of change you're going to get. That's why really the clinical trials need to be run to determine, okay, if you do this for a month or 2 months or 3 months, what would be the indication? And then look for biomarker changes as well. You could do the behavioral analysis, cognitive analysis, activities of daily living. You could do also biomarkers from blood and CSF to see if that's changing, maybe PET scanning for evaluation of imaging amyloid in the brain. And so there's a variety of mechanisms you could approach there and ways you could do the clinical trials. At this point in time, it's just guesswork. If somebody has a urinary tract infection, for instance, and they're treated with an antibiotic, there are many times that person, if they've had neurocognitive change, actually become more lucid. And but that could be also, to be fair about this, is that you have cytokine responses in the bloodstream. And you're getting now an inflammatory process that's peripheral that's affecting cognition. Because, for instance, IL-6, this is a cytokine that gets secreted from monocytes and white blood cells. That can have an effect on the blood-brain barrier to now lead to transient opening or transient change to make it more leaky. If that's the case, you could now be having cognitive change because of a blood-brain barrier issue. So it's not as clear cut. Also, the gut microbiota and what we're finding with gut microbiota, both with bacteria and viruses in the gut, could have an effect systemically, and it could show up in the brain. I wanted to just go back to one quick point about the olfaction issue. You know, with COVID-19, we're seeing that olfaction is impacted big time. And then you're also getting neurocognitive effects as well in quite a few people. And I think that's a key pathway that needs to be considered, because even though in COVID-19, the virus does not seem, for the most part, to directly enter into the brain, you're getting inflammatory responses generated. And those responses are sort of leading, I think, to now this neurocognitive deficit, brain fog, cognitive difficulties, memory changes. So in a way, what we're seeing here with our pandemic is mirroring what we've been studying with these other organisms and how they may be leading to an Alzheimer type problem.
Yeah, I'm glad that you brought up COVID, because I was actually wondering, reading the research and realizing that, you know, COVID, there isn't a presence of COVID in the brain. I believe in autopsies that they've conducted, but why then is it impacting the brain? Do we know the answer to that? I mean, it's obviously an inflammatory response, but why the brain fog? Why the memory loss?
Well, I think olfaction being impacted, even peripherally, is now changing what's happening in the olfactory bulbs and connectivity into the brain, but it's also the blood vessels in COVID-19. This virus, CoV-2, can infect the endothelial cells, so affect the blood-brain barrier. In so doing, you will generate an inflammatory response and a change in blood-brain barrier that can have these types of consequences with neurocognitive change.
Then
There's
we have
also-
another. Oh, sorry. Go ahead, Ruth. Did you want to?
I was going to say there's another possibility which could explain quite a lot of things, particularly that infections lead to cognitive deterioration and might eventually, they seem to enhance the risk of getting dementia or Alzheimer's. The possibility is that inflammation in the brain can reactivate HSV1, herpes simplex virus type 1. And so it's quite possible. We've doing some experiments which suggest that that is actually happening with at least one infectious agent we've looked at. We hope to do several others. So that could be a much simpler explanation for, also an explanation for damage caused by head injury, because it's known that damage to axons in brain, as connections in brain, does reactivate HSV1. It's quite easily reactivatable. There are quite a lot of events that cause its reactivation. Certainly inflammation causes it. The curious part, though, is that infection with HSV1 also causes inflammation. So it's a vicious circle, which makes complicated ideas, really. Sorry to interrupt.
No, not at all. Thank you for that. I have another question that has come in that's relevant to this part of the conversation, which is P. gingivitis bacteria a plausible cause and effect of Alzheimer's disease? And can we simply prevent it by maintaining oral hygiene? So, you know, the olfactory through the gums route, do you have any comment about gingivitis? And it is important to floss and brush in order to protect your brain.
So maybe I can address it from the clinical side, and perhaps Brian and Ruth can talk about it from the basic side. So normally what goes on in the oral cavity, when we go to the dentist, it's sort of separated from the brain, as it were. But other than the fact that when you feel pain or you're unhappy about it, you get a reaction, but that's not an organism going into the brain. So what may be happening is that with the gingivitis, there's a very low-grade infection that can directly or indirectly influence the brain. The one good piece of news is there actually is a clinical trial going on with agents to treat gingivitis, placebo-controlled trial going on right now. I'm not sure when it's supposed to end. So we'll get some answer to that question. If you aggressively treat gingivitis with antibiotics and related agents, will you be able to decrease cognitive decline or improve it to some degree?
I mean,
Brian, would you have any thoughts on that?
Yes, I think that you could approach it that way. I know they're using a protease inhibitor type of drug to try to prevent the gingipains. These are enzymes that are made by that bacterium from damaging brain tissue. They get into brain, activate apparently, but it goes to that this is an anaerobic type of organism that stays in the gums where it's not as well oxygenated. It could also have influence on the vasculature by now influencing inflammation now systemically that can have an influence again in the brain. And as Ruth had mentioned too about the reactivation of it. So this may be a huge cycle with potentially multiple organisms that could have an effect depending on the individual and other risk factors, like if they were ApoE epsilon 4 positive with that genotype, or if they live in a highly polluted area where now air pollution is having an effect as well. So there are different factors here, and that's why it's a real difficult process to prove you have one factor causing the problem, and without looking at all the other factors as well.
Okay, and we have another question. This viewer is asking, does the variety of microbes with the capability to impact the brain directly or indirectly call for a more precise approach to analyzing and treating patients?
Well, diagnostically, we are looking for specific infectious agents. So for example, herpes simplex virus, slightly more than half the population has had HSV1, but then a large minority have not. So, and one argument that against the infectious hypothesis is, well, there are plenty of people who get Alzheimer's and you test them for antibodies, they never got herpes simplex, so they never got this or that. But that comes back to Brian's point that there are multiple ways you may get Alzheimer's, or you have multiple factors contributing to different degrees and not just one agent. And, translating from a theoretical concept, okay, let's try and treat multiple possible infections, diagnose everybody in great detail. That's difficult to do practically because we will need to do a large number of diagnostic tests to cover the whole range of possible infections a person has. And while we've talked about giving multiple antibiotics or antiviral drugs, it's important to recognize that when you start giving high doses for long periods of time, you have to be careful. There are clinical side effects, and it's not so simple. So translating from a theoretical construct to clinical use is hard, and that's why the intermediary in that is clinical trials, to make absolutely sure that you really need to do that.
Okay, and so this is apropos to that last comment. And Ruth, I want to get your views on this too. Is there enough research going into this hypothesis? And one viewer is asking to please describe the number and nature of the trials currently underway. Is it, I hope it's not that short a list that we can actually talk about it on this video, but Ruth, over to you.
Well, I think Deb would answer the question about clinical trials, but there's certainly not enough money going into research for Alzheimer's. The other thing is, Brian mentioned ApoE. This is a particular protein of which one type is known to be a risk factor for Alzheimer's disease. And I should say, to augment what Deb said before about people who have got the virus and don't get Alzheimer's. Well, in fact, the proportion of the population that is infected with herpes simplex is something like 70 or 80% by the age of 60. There certainly, luckily, is nothing like 70 or 80% of the population has Alzheimer's disease. Otherwise, we'd be in a pretty ghastly situation. And the reason is that we found, this is one reason, there may be other reasons, but in our work, we found that it was a combination of the virus in brain, herpes simplex virus in brain, in people who carry the type 4 allele of the ApoE gene, who are the ones who are at risk, who are most likely to get Alzheimer's disease. Those who don't have that allele are not so likely, are pretty unlikely, really. And so the proportion that have an ApoE4 allele is only about 25 to 30% of the Western Europe and American population. So it works out anyway, and what we found was that roughly 60% of people with Alzheimer's disease, 50 to 60, one could attribute as a risk, as a cause, probably, the combination of herpes simplex virus in brain of ApoE4 carriers, people who have that particular allele. So people can have herpes and be completely asymptomatic. In other words, they don't have any trouble. What we found also was very interesting was that people who have cold sores, which is usually caused by herpes simplex virus type 1, some effect in the periphery, they show symptomatic symptoms of herpes simplex virus by having these cold sores. They also, majority have an ApoE4 allele. So again, in the periphery, it's a combination of the virus and this genetic factor that gives a strong risk.
Did it matter if they were homozygous or heterozygous, meaning one copy or two copies?
Yes. Well, you're more likely to get Alzheimer's disease if you have two copies, certainly. So yes.
But in relation to the virus hypotheses,
we weren't able to do that because the proportion of people who are homozygous, who have both copies, E4, is quite low, and we never had enough money to search high and low for specimens from people of that sort. So it is something where you need quite a lot to prove statistically what you're saying, and this just wasn't possible.
Dev, do you want to comment on the ongoing trials? And this is a good time to maybe put the pieces together about what we do know and what we need to know, and how we should even approach this hypothesis.
I think it is a good time to review things a bit. There are many associations with different agents, pathogenic agents like viruses and bacteria, environmental problems like pollution, even physiological factors like diet, exercise, cardiac disease, that are all been associated with increased risk for Alzheimer's. But when one tries to do clinical trials, it may or may not work. So one great example, people who took anti-inflammatory agents like ibuprofen and naproxen, other anti-inflammatory drugs for various conditions, arthritis and so on, most of the studies showed it prevented Alzheimer's. But when clinical trials were done, they failed. You couldn't show that effect. So the clinical trial, in a way, at least for now, is our gold standard. For the viral hypothesis, I'm doing a couple of trials, one with Valacyclovir versus placebo and mild to moderate Alzheimer's. We'll finish recruitment for that study in the next few months. It's listed on the National Institute of Aging, NIA website. You can learn about it there, and also in clinicaltrials.gov, G-O-V. Then I got funded by the Alzheimer's Association for a smaller study to look at people with mild cognitive impairment, which is generally a sort of stage between normal and Alzheimer's. And not everybody with mild cognitive impairment is going to get Alzheimer's. So in that study, we also require amyloid positivity on PET imaging. There is a small study done in Sweden by Hugo Lovine's group. That's an open study. I believe they have 33 people in that study, looking at when you give Valacyclovir, what happens to the brain and peripheral biomarkers. So they are, I believe, towards finishing that study now. One of the reasons all these trials are going on now is that 10, 15 years ago, every grant that was submitted with the viral hypothesis and doing a clinical trial ran into roadblocks. And Ruth and Brian are smiling. They've been through that. I myself went through that several times. And only in the last 5 to 10 years, because of increased funding for Alzheimer's, there's been a realization we need to be broad in looking at possible therapeutic agents. And so the viral hypothesis, the broader infectious diseases hypothesis, which was in the bailiwick of Brian, Ruth, and others, the main Alzheimer's field was not very interested in it, but now they are. So because it's not just the infectious hypothesis, there are many other ideas being thrown around. So before going to a huge clinical trial, there has to be some signal from smaller studies before one gets that level of funding. So we're right now at that stage. In a couple of years, we would have enough information to know whether this makes sense as a clinical intervention or not.
I mean, it's
to pursue and further
we have the animal studies, right? But it needs to move on to humans. Is that fair to say?
The animal studies, but a lot of epidemiological studies. We've talked about the electronic medical record studies. So there are a fair number of human studies, but it's more correlational, association rather than a rigorous clinical trial. So we've moved quite a distance, I would say, in the last 5 to 10 years.
And perhaps COVID and all the research around COVID and long-term lasting effects can really help this area to push it down further. But one viewer asked this question, and I think it's a good one, which is, can COVID become a bacteriophage of chlamydia and travel with it? So is there the possibility of one virus meeting another, or is chlamydia considered a bacteria or virus?
Chlamydia is a bacteria.
Okay, so could they collide and unite and become something else? Is that way too futuristic?
We don't think so.
Okay.
No, but you potentially could have co-infections or polymicrobial infections. So that's a possibility. Our hope is that the CoV-2, the COVID organism, is not getting into the brain and is not setting up shop there long term. There are some studies that are out there that are proposing to look at that and to look at how that would relate to Alzheimer's disease as well and to dementia. If it goes in that direction, this will require prospective studies going downstream. We're hoping this does not lead to, with COVID, an increase in young people developing dementia. It's a hope at this point in time. We're not totally sure. With the people that are suffering long-term effects, what does that do? Will it set the stage? Like, for instance, if you could use the analogy of a traumatic brain injury giving you increased risk for now developing Alzheimer's disease in later age. Well, could something like this set the stage for that? We don't know. And that was going to be an important question to ask.
And we found that is a possibility with CTE and football players with the injuries in sports, that it really unleashes the pathology and puts people on the road. So it's not too far out there. Scary to think about, though, given the amount of people now who have had COVID on this planet. It's scary to think about that. But yeah, let's hope that we can determine more. I want to go around to conclude, because we're almost out of time, about like, hopefully that some of the funders out there, or the NIHs and are watching this. What do you think is, and I know, two of you are basic science, one is clinical, but what is your basic wish for the next stage of funding for each of you personally? Where would you want to go to really put the next piece in the puzzle? Brian, let's start with you.
Okay, I think we need to develop consortium approaches to this. This needs a major collaboration, probably through multiple countries, multiple approaches, with funding that is coming from our NIH, other national healthcare organizations, even in other countries. This is something that's a worldwide problem. So we shouldn't just consider that it's an NIH issue. Now, I wanted to say NIH is having, I don't know if you know this or not, they're having a meeting in early October, the 5th and 6th of October, to discuss this issue with infectious agents and Alzheimer's disease and the pathogen hypothesis. I think that we're going to have to get to a point where we decide, in order to prove this, that infectious agents are involved, it's going to require clinical trials. We have to get to a point where we're deciding this is the time, instead of delaying the process and saying, okay, well, how much evidence do we need at this point in order to say, let's go forward with that approach? Now, that could be debated, but I think that if the NIH can't do it also, by the way, if they can't use the almost $3 billion that's now been allocated for Alzheimer's research to now increase that budget, the budget currently for infectious agent research is about 6 million of the 3 billion. So it's only a drop in the bucket. We need to change this paradigm and move to having a much more a larger pot of money to be put behind this to really get to that answer. But it goes to the clinical trials again. So I'll stop there.
And Ruth, if someone was going to give you £1 million for research, what would you do with it?
Well, I'd need several million. I would do a clinical trial very similar to the one that Dev is doing, but I would add another antiviral agent which acts by a completely different mechanism from the agent he's using, so the combination of the two could be particularly effective. As far as for research goes, I think one of the most important questions that really has been raised during this conversation is Alzheimer's caused in different people by a single organism, or is it caused by a combination of organisms? And are they always the same ones, or can you get a sort of pick your choice of organism combination, so that in one person you have A and B, another person you have C and D? And I think this is not impossible at all to find out, but it needs a fair bit of money. I've actually had a grant with other people on that topic, but unfortunately one of the main persons involved died quite suddenly, so that's put on hold for the moment, but we're hoping to recover it, because I think this question is extremely important. And
which antiviral are you studying, Ruth? Which one?
Herpes simplex mainly, but also we've been looking at varicella zoster, which is the one that causes shingles, getting some very interesting results. So I think that's what I would do on the experimental side, and I've said what I want to do in the clinical side.
Okay, and if anyone's watching, she doesn't want 1 million, she wants 3. So
you said what I should have said. Clinical trials are very, very expensive.
Yes, I understood, as it is. And Dev, over to you. What would you do with maybe 3 million?
Well, my study is funded fairly well. Part of the reason these studies in Alzheimer's have become more expensive is they want PET amyloid imaging, maybe tau imaging, and the clinical research itself with patients is expensive. When you add in all these expensive brain imaging procedures, it gets quite expensive. I think even though we're talking about clinical trials, and that's what I do, and I'm doing a couple of trials, I also think getting a better handle on the mechanisms that lead to this type of Alzheimer's pathology is worth doing, because I know Ruth has done some, Brian has done some, but it's not something that has been done in a widespread manner in the field yet. So
Can't we
I
do
would
that without, sorry to interrupt, but can't we use a blood test to get some of this information? I mean, it's being used now to detect plaque in the bloodstream, and there's biomarkers, obviously, of Alzheimer's in your blood that are detectable.
Yeah, the biomarkers useful for diagnosis, but clinical diagnosis is fine too. So the biomarkers are an add-on by itself. It's very unlikely that the biomarker will be like doing a hemoglobin A1C for diabetes. Very, very unlikely. So I think in terms of diagnosis, which you're raising as an important question, there are many ways to make the diagnosis, and it's converging lines of evidence that help us make the diagnosis. But just like with the antiviral treatment or antibiotics, I think we need to see a signal in a clinical trial. These are what come under the category of phase 2 trials, what we are doing and a couple of others, before I think funders, whether it's NIH or foundations, will go to fund a very large study with a huge amount of money. And so we're keeping our fingers crossed, because if we get that type of signal, I think it's worth proceeding. So what I'm trying to say is, just like with the FDA, you have phase 1, 2, and 3. We are basically doing phase 2 trials, and phase 3 are the really big, expensive trials. Like, for example, the Pfizer and Moderna trials were phase 3 trials. And I think everybody knows they cost a fortune. So we just are hoping that we'll see a signal. And as Brian has pointed out, look at multiple possible organisms, use multiple approaches, which does require funding, but that again would need to be in a phase 2 level just to see whether we're getting a signal. So we're talking about 50 to 100, 150 patients and not 500 to 1,000.
But just to be very clear, this is one reason. Like, I think science is coming to agree that Alzheimer's can be a result of many different factors. So the virus or the bacterial microbes is just one. It doesn't mean if we find the answer to this, then we're going to eradicate Alzheimer's across the globe. Does everyone agree on that? It's just,
yes.
It's one pathway, and it's the root cause of possibly some people out there who are ending up with Alzheimer's disease. But what this means is, if we understand that it is indeed a root cause, we can stop that cause in patients who would have maybe not otherwise gotten Alzheimer's disease. And that's a big thing in itself.
Prevention is vastly better than treatment. There's no cure. And there are signs there might be some ways of prevention, which is really premature to talk about, but that would be far another thing which I would use 1 million or considerably more.
Okay, well, hopefully this has been a very fruitful discussion, both monetarily and just in knowledge. I want to thank the three of you for your time. I think this is a topic that is very much worth exploring more. And I ask that you please keep us abreast and up to date with your research. Being Patient is a platform to really translate and relate the science to the general population and people like myself who have been impacted by dementia. There's a lot of us out there. There's a lot of us really hoping that to find some of that science, find some of the answers. So your time spent with us is greatly appreciated. I have a huge amount of respect. I've read, about all of your research, and I have a huge amount of respect for what you're doing, trying to find some of the answers. Although today they're outlier hypotheses, we hope that with more research, we can bring that into the more mainstream. So thank you, Dev, Ruth, and Brian. Thank you so much for your time today.
Thank you.
Thank you.
Goodbye.
And if any of you missed any of this interview, please go to beingpatient.com. Don't forget to sign up to our newsletters. That's where we tell you about getting these type of experts, top quality experts, to talk to you, answer your questions. Thanks everyone for watching, and we will see you next time. Bye for now.